I just wanted to thank everybody for being part of our 10-year celebration and for this conference. I think that the partnerships that you create in these kind of events, transcend patient care and allow connections to happen for the people of this region. A couple of things I'd like to remind. You have spent the time, the effort, the energy to be here and learn. Gather your CMEs. So it has to be done before December 7th. Your packets should have all the information on how to do that. You can't call us on December 8th and ask for permission, special permission to get your CMEs. We do not have the power. The TMA it takes that away from us on December 7th. Okay. So please fill that in and make sure that you get the reward you need. We have, I'm just going to say it right now. I'd like to conclude this year's event with thanks to the faculty, the attendees, the sponsors for improving vascular outcomes throughout the region with education and collaboration. And we have one more video that we're going to play and really with a kind of a deep dive on women's health and some of the things that we've experienced over the last few years working in the deep venous space, what we've encountered, and really to try to explain some of that. We're hoping there's questions that you guys can ask, and then we'll wrap the session after that. We'll comment while the video is going on, and that way, and if there's any questions, raise your hand. I'll just walk out to you to give this to you, and we can make sure we get all the questions we need.
Our protocol definitely kind of mandates that, or we typically will go after the suprafusional system first in a large majority of patients. However, if their symptoms suggest that they may more benefit from deep intervention, then obviously we'll tackle that. So, you have to look at the whole patient. You have to look at their symptoms. It's never clear cut. We have a very mid-level focused practice with a lot of nurse practitioners who see these patients initially, and they want it to be, proceed to A, proceed to B, but sometimes it takes a lot of, it's complex to determine which route to go with some of these patients. Now, that being said, venous disease is incredibly prevalent. Like Chris said, upwards of 30% of Americans have some element of venous disease. And if you walk around outside and people in shorts, 1 out of 3 people have large bulging varicose veins and skin changes and things like that. So, it's an underserved, underappreciated issue, and it really can change people's lives if you treat them better and make them better.
A lot of the work now being put to the outpatient world, we have more time to actually focus on venous disease. So when we first started doing this, we found a lot more May-Thurner obstruction that we had to treat in our practice. We're going to do the first run. I think you're fine.
Yeah, Chris, it's interesting. I mean, if you look at hospital ultrasound, so like if you order a venous ultrasound in a hospital, nobody goes above the inguinal ligament. And a lot of people who don't have a good vascular lab or have to get CT scans of the abdomen and pelvis to really evaluate these things. And the venous system is so dynamic that it really lends itself towards an ultrasonographic interrogation of the patient over a say a CT scan. And so that's why it really also lends itself to an outpatient workup. And we're just sort of more efficient in an outpatient setting. So I 100% agree with you.
So we just injected, was it 10-half? 2 10-halves on both sides. Just got to get a sense of where we were. I'm not seeing the filling I want to see. So we're going to shoot a little bit here and do a little technique where we're injecting simultaneously. And I'm going to move us just a little bit, like one. Okay. Yeah. Let me take this. This one right here. So we're going to inject 10 cc's of contrast each, and then follow it with some heparin flush. 1, 2, 3. You run, please. Long run. 1, 2, 3. Okay. Much better. Keep going. Keep running. Keep running. Keep running. Keep running. So you see all the pelvic vasculature.
All right, so we're just going to turn the voice off just for a minute and then let the video play some. This is similar to what we had earlier today in the live case, and it's a patient though that has compression of the distal vena cava, bilateral common iliac, and her main complaints, and you can see that the connecting points between the two across the pelvis in those collateral branches are very prominent, and so one of her main symptoms is low abdominal pelvic pain. That was her symptom, and she's been seen by GYN, she's healthy, everything is normal. She continues to have problems with this horrible pain. That's a daily problem, worse during her cycle. And I believe she also had a ovarian vein with reflux that was present. And so that's a real clinical conundrum. What do we do when we have, May-Thurner obstruction and ovarian vein reflux? Because the distal vena cava, or the vena cava, the end of the vena cava and the iliacs are compressed, all the flow goes through the pelvis. All the flow goes through the internal pelvic branches. And that's going to range right around the uterus, the bladder, and in that low pelvis. And so these patients, when they have both things going on, our question is, well, which one do you fix first? And I think the answer, Will, is what's the answer for that? Go ahead. Dr. Cuozzo?
I think the obstructive disease, the venous obstructive disease, is such a powerful force, and it really changes the whole dynamics of the fluid volume in your body that we've seen. And I feel like that's probably the best place to start. I think we can make real changes there. We can change the dynamics. We change the obstruction. We don't carry as much blood volume in our legs anymore, and I think that changes the whole distribution of your blood volume in your venous system. So I think that makes the most changes, the reconstruction of your venous side.
When you understand the amount of blood that's coming through that iliac vein per second, per minute, it's on the order of about 1 liter per minute. So your cardiac output's about 5 liters per minute. 20% is going to your brain, 20% is going to your chest, 20% is going to each leg, and the other 20% is probably your viscera. When that iliac vein is compressed or blocked, all of that blood is dumped through the pelvis, and people have, what we call, here I'm blanking on it, pelvic congestion syndrome. And one of the problems is that it's a fairly common complaint of the female population with their GYN, and they don't always get an answer. And one of the things we like to highlight is the fact that by fixing the May-Thurner obstruction, it actually fixes the pelvic congestion symptoms about 2/3 of the patient. So if you have both problems, the literature that we've reviewed and our personal experience is that by fixing the May-Thurner obstruction, that relieves the pelvic flow, establishes the flow back to the vena cava and the heart like it's supposed to, and that often relieves that pelvic discomfort that the female patients have. This can be a male as well with gonadal vein reflux. It's usually testicular pain, low pelvic pain, worse if you lift or do things like that, exercise. But the predominance of pelvic congestion is female in origin. Sometimes after the stents are placed, patients will come back and they say, they hug me and they say, thank you, it's all better. Sometimes they come back and say, no, I still have pain and it hurts right here. They can point to it. And that's usually their ovarian vein reflux at that point that needs to be needs to be addressed. We've been learning a lot about May-Thurner syndrome. Some of the things that we've kind of discovered over the last few months, even year or so, is the fact that there's a lot of different syndromes that go hand in hand. So you have an obstruction of the vein. So yes, it can cause swelling in the leg. That makes sense. It can cause pressure, heaviness, achiness in the leg. That makes sense too.
We're going to present a case of patient ZK.
One of the things that we found is that a lot of patients have improvement in their ability to walk, breathe, exercise. And part of the reason is when you have a blocked vein as large as that vena cava, patients do not get the return to the heart of the blood that they need. And so they're often labeled as having POTS syndrome, so postural orthostatic tachycardic syndrome. And that's when our brain and our heart work together so that whether we're laying down, sitting up, or standing up, our blood pressure is maintained. It wants to maintain our blood pressure at a normal level so we don't feel like you're going to pass out. When you don't have that connection, when the brain and the heart don't talk properly in the autonomic nervous system, that's the system that controls our regular breathing, controls our heart rate. And so if you don't have, if that's malfunctioning, then when you sit up, when you stand up, you get faint. You're like you're going to pass out. A lot of these patients have that condition. And it's often a true autonomic nervous system problem where the connections aren't working. But there's a lot of POTS going on out there. And there's a lot more POTS going on out there since COVID happened. Since that time, we're seeing a lot more venous insufficiency like this. And there's an additional syndrome called mast cell activation syndrome, where there's an inflammatory component to a lot of the patients that we see.
Deep dive and go
that
back
can
in.
affect
And now you've got documented evidence.
our
of
GI tract, our
and
mental
that's
fog,
really important when you're talking about
our skin conditions. And we see, if you look at the Venn diagram of diseases, they all kind of coalesce right around this venous obstruction. So there's more to this than we think. Possibly that venous obstruction is causing an inflammation process. Mast cells, are you good on this?
Yeah.
Mast cells are the ones that release the histamine that cause the mast cell activation problem and the fog and the skin conditions and the GI disturbance. So more to come on this. I think these patients are extremely complex. If you think the superficial venous patients are complex, these patients are about 50 times more and often come with multiple diagnoses, multiple medications, seeking help. We've had a number of patients that have traveled from all over the country to come to VIC for therapy, and we feel blessed about that, but it's going to continue to increase, and partly because we think we have a good understanding of this problem and are at least willing to talk to patients and help them figure it out. Let's see if this next section works. The last section, the stents went
obstruction,
great, perfect,
she was noted
and
to
now
have
it's Harris' turn.
So we did a pelvic ultrasound. Can you go to the next slide? The pelvic ultrasound was, the iliac vein stent is wide open and looks really, really good. Go to the next slide. Our ultrasonographer, she's a pretty thin woman. So it's pretty easy to visualize with ultrasound her gonadal vein. And a lot of our ultrasonographers are pretty well trained at looking for that. And so they measure not only the diameter, but also to see if there's significant venous reflux within that gonadal vein. And so they were able to tell, you can see on that slide that her gonadal vein actually has pretty significant reflux, something like 1,200 milliseconds of reflux on her study, which is pretty substantial. And she's got a good sized gonadal vein for her size. It's around 6.5 millimeters in diameter. And so those are all kind of characteristics some people who don't have as good an ultrasound, you may look for it on CT scan and see if you can visualize it that way. That's another way to work it up. But our protocol is ultrasound first, as I was talking about earlier. So in this instance, I think she's already had the kind of iliac venous compression treated. So I think the next logical step for her is coil embolization. So we'll get in.
So,
Here,
Dr. Harris?
Yeah.
So you mentioned the iliac venous compression. Is that synonymous with May Thurner?
Yes, sir. Yep.
Okay.
That's exactly
In
it.
that case.
So May Thurner is it was first described by May and Thurner in the, I don't remember what year, the 30s or something like that. But
So-
that's all it is iliac venous compression. So
For
what
these
cases?
cases,
What's that, Steve?
I was going to say, for these cases, this is often staged because of not just the presentation of the patient, but to make sure that insurance will cover these. And therefore, you have to treat that iliac venous compression and then
1,000,000%.
evaluate for pain and bring back. Is that how that is?
It's that.
I think we just lost our feet a little bit, but this is a patient who had a previous iliac venous obstruction, who was treated with a left common iliac venous stent, and has still persistent symptoms of pelvic congestion. And so, if we can make this froze for just a second, the internet search. But in a patient such as this, who presents with iliac venous obstruction, I think it's really important to have a long conversation with the patient. And because so many of these patients are somewhat young, and so if we're putting a stent into them and say they're 30 years old, they're going to ask what that stent's going to look like in 50 years. And that's a hard conversation to have because I don't know what it's going to look like. These stents have only been on the market for 5 or 10 years. They're FDA designed, indicated, and developed by people probably a lot smarter than us to be in the system for 50, 60 years. But it's a conversation you have to have with the patients when you put these things in, because it's not something that I can take out willy-nilly. And so, or with any ease whatsoever. And so Chris got to the end of the case really, really quickly on his scanning right there. But what we're going to, in a patient who presents with pelvic congestion, I have a long discussion with them as to whether or not it's worth treating the gonadals first, or if it's worth treating the iliac venous obstruction first. And when I do that, I counsel them that the patency on the stents is good for the data that we have, for the time that we have available, but it's a much more permanent thing than coil embolizing a gonadal vein, and they may develop complete relief of their symptoms if they're only pelvic with coil embolization of the vein, which is a little bit more minimally invasive, has less pain, things like that. But sometimes the patient will have concurrent, lower extremity symptoms and whatnot, and thus I think fixing their iliac venous system makes sense over necessarily going after their pelvic system. You guys kind of have the same philosophy?
Yeah, absolutely. I think so. One of the things I'm impressed though with is I've had a number of patients where we fix the May Thurner, they have the lower extremity symptoms, that's better, and their pelvic pain is gone. And I think that's that major flow, the rerouting of the major flow of the venous system through the pelvis is a major contributing factor for a lot of these symptoms. And I've not treated it the other way. I've not done ovarian vein first and then had to come back and do May Thurner stent reconstruction. Mm-hmm. So far that pattern seems to hold, that 2/3 are better with May Thurner reconstruction, and then 1/3 you add in that additional ovarian vein embolization, which you showed right there.
Right. So in this case, in this instance right here, we've got a catheter in through the right common femoral vein access, and we've put the catheter into the gonadal vein, which you can see kind of coming down right here. Catheter, it takes a trick, and it's taken us a long time to find a catheter that we like that just dumps into that gonadal vein. But we've got the catheter extending all the way down kind of into the pelvis. So we actually, for those who can't remember their anatomy, and I'm one of them, you go through the inferior vena cava and go into the left renal vein, and then the left renal vein, the gonadal vein dumps into the left renal vein. So through the renal vein, we actually go into the gonadal vein. And this is a good image here of pelvic congestion. Frank, do you want to kind of describe what we're seeing here?
Yeah, so here you're seeing a significant amount of reflux into the gonadal vein, and you're seeing some transpelvic collaterals forming, and this is can be the source of this venous congestion. Just too much blood in the system there, which can cause pain, swelling, and dyspareunia as well. That's a pretty classic finding.
So with that, what we'll do is we'll inject contrast in there, and the blood flow is supposed to return very briskly up through that gonadal vein. But when you shoot a pelvic congestion patient, that blood will kind of pool down there and not return at any rapid rate. And so the way we treat that is by putting in those little metal things that look like rubber bands piled up, and they're little metal coils. And those coils go into the vein, and if anybody remembers their high school freshman biology, how are platelets activated? Platelets are activated through turbulent flow, and so the coils create turbulent flow, causing platelet activation and cause those veins to thrombose. There's probably a better picture of the next. Go for it. So we put the coils into the vein and build them up. And usually in a gonadal vein, it takes 2, 3, 4 coils, something like that. We also inject a solution into there to irritate the inside of the vein, not dissimilar to what we do for Varithena, which irritates the inside of the vein and kind of is an adjunct to help close down those veins. So you can see we kind of build up that coil platform all the way up into up higher to ensure adequate closure. When they do this, patients really have no symptoms afterwards. They go home, typically they never have any back pain or pelvic pain after the procedure. But the idea is, again, to transfer flow to the path of least resistance. So if you have a dysfunctional gonadal vein or ovarian vein, that reroutes the blood flow to a lower pressure, higher flow system to kind of decompress the pelvis. Would you say that's kind of an accurate?
Yep, absolutely.
So here, this is a, it looks like I'm trying to put another coil in right there. A lot of the coils that we put in are either pushable. You put the coil into the catheter and then push them out with a little, with a wire. And sometimes you can pack them in different ways. There are other coils that you can put in that are connected to a wire that are electronically triggered. And so you put a charge through the coil and it actually releases the coil that way into the system. But if you don't like where it's placed, you can pull it back out too. So that's a nice function of those.
And this essentially, just imagine a varicose vein in the pelvis. This is shutting off the inflow to that. And so as you kind of fill that vein and that closes, then that should take away a lot of the pressure in the pelvis and relieving a lot of the symptoms. I've at least the patients we've done, I've not had anybody that said they wouldn't do that again. They have a significant relief from this. That's usually more of a constant kind of pain every time they sit or stand.
And that procedure is pretty fast. It only takes maybe 20, 25 minutes to actually do the procedure. Once you get into that vein, that's the hard part. So once you're in there, the diagnosis is very quick, and then delivering the coils is very quick too. And of course, it's an outpatient procedure. They go home that day.
So any questions about pelvic congestion, May Thurner? Any other comments?
Yeah, one comment. It's been mentioned several times today about venous stents, iliac venous stents in young people, and some of the concerns that you might have with that. I would say in the past, the way that some practices put these venous stents in, they put them in and they forget them and they don't do anything. They let the patient go on their way. That's not what this practice is all about. I think we have confidence in putting venous stents in young people because they get a maintenance plan with those stents, and they get strict surveillance. And we watch them, and that when you do that, you're going to increase their longevity and their durability, and I think that makes the difference.
Mm-hmm. Yep, very much so. Well, I'm going to blame this on the weather that's coming in, and I think we're probably going to wrap this session. Is there any other questions at all we'll be happy to entertain before we close? If so, then thank you all for being with us today. It has been a lot of good knowledge that we're trying to share, and I appreciate all of the speakers that have traveled to be here with us. Please be safe on the way home. It does look rather challenging out there, so be careful. And I will expect you all back to work on Monday. Okay, thank you.